All right. I am not seeing too many more people trickling in, so we will get started. Thank you guys for joining our webinar today. My name's Kellen. I am FARA's Patient Engagement Manager, and I'm excited to introduce everyone to Franca Angeli, who is from Lexeo. She's the Vice President of Clinical Development and Cardiology. And today she's going to be talking to everyone about cardiomyopathy in FA and the phase 1/2 trial that Lexeo had ongoing to investigate LX2006, which is a gene therapy that targets the heart in FA. So I'll turn it over to Franca.
So it's a great pleasure, and thank you for this amazing opportunity to be here today. A few disclosures and disclaimers. So as Kelly mentioned, I'm a full employee of Lexeo Therapeutics. We're going to be discussing some preliminary data of our compound, the gene therapy LX2006. So just as a reminder, safety and efficacy for this interventional agent is not being proved yet, and therefore some of the data and some of the content may be forward-looking statements. And with that, can we go to the next slide, please? So why we are here and why we are so thankful to be here, because connecting with the FA community is key to where we do Lexeo, is by listening to you and to your families that we actually are able to develop better products to serve your unmet needs, but also you are an inspiration to all of us. We are very lucky to be part of the community and even more pleased to be able to actually sponsor a focus group this weekend at the Philly Shop FARA event. It's going to happen Saturday, Sunday, and Monday. So we are looking forward to see all of you there. And of course, we are always grateful to have participants of the community in our headquarters in New York. Again, you provide a lot of inspiration to us, and you will provide a voice that lead what we do every day in our work. So thank you. Can we go to the next slide, please? So we're going to start today with something different, and it's going to be, I believe, the first time that we're going to be doing that is a polling question. We're going to be asking you to answer this question. Were you able to attend the FARA Community Conversations webinar for genetic therapies? Please click yes or no. Looking forward to see the results. Okay, very interesting. More than a half of the people were able to watch the community conversation webinar. If you have not done, I actually highly recommend that you take a look. It's very nicely done. It provides a lot of important information. One of the key things that I believe is important for each one of us as a patient or a family member is to actually do informed decisions, and this webinar actually provides super valuable information for everybody that is involved or may be involved with genetic medicine. So thank you, and let's go to our next slide, please. So today we're going to separate this talk in 4 blocks. They are a continuum, but hopefully address initially 3 different topics. Talk a little bit more about cardiomyopathy and FA. Hopefully then segmenting that to our next step is discussing a little bit of gene therapy, and specifically LX2006, which is a investigation gene therapy aiming to treat cardiomyopathy and FA. Looking at some preliminary data from Lexeo2006 gene therapy. There are 2 trials ongoing. We're going to talk a little bit about that when the section comes. And very important, my favorite part of these discussions is the Q&A. We hope that we are able to connect with you and hopefully answer the questions that you may have. So can we move to the next slide, please? So what is this is FA and what is the frataxin gene? I'm pretty sure that the majority, if not all of you in the audience, know more about frataxin than I do, but I love to provide my 2 cents on the frataxin gene. So genes, they represent all the genes together. They make our genome, which in a simplistic way, I always believe every gene has a manual of instruction to produce certain proteins or elements that are needed for our body to fully function. So each one of the genes, or sometimes a combination of genes, they're responsible for providing instructions to our cells to produce a protein. In this case, we are talking about frataxin. Frataxin is a key protein for making energy in our body. Not only that, by making this energy, they protect our cells from injury. So what happens in frataxin is essential to the mitochondria, which is pretty much the powerhouse or the power energy plant for our cells. Without frataxin, the mitochondria or this powerhouse is unable to make enough energy for our body functions to function in a way that we like to see. So what happens in FA? There is a change, or also sometimes called a mutation or a variant in the frataxin genes that leads to a manual instruction that tells the cells to produce frataxin, but not in the quantity enough to supply all the energy that we need to have to function properly. If we can go to our next slide. And so what that means for somebody that has a FA. Because you have the mutation and you have low production of frataxin, usually leads to low energy production. There are, of course, some organs or tissues in our body. They are the ones that use the most energy. And therefore, and unfortunately, they are the ones that usually are the most affected by FA. So not surprising to you, you're going to see the brain, the heart, and the skeletal muscle are the ones that are more affected. As you may imagine, even when we are sleeping, our actually brain is still working. Same thing for the heart. Even when we are sleeping, the heart needs to beat around 60 times a minute continually, 7 days a week, 24 hours a day. So when you don't have enough energy to do that, unfortunately, the cells of the heart and the cells of the central nervous system, which includes the brain and the nerves, they unfortunately are the ones most affected by the disease. And that leads to some of the expressions or the findings, the manifestations that you are aware of it, including poor balance coordination, vision loss, heart problems that we're going to talk more today, fatigue, walking difficulties, tremors, and inability to speech or impairment of speech, and impairment in swallowing. Next slide, please. Another polling question: what heart condition can occur in FA? Neuropathy, cardiomyopathy, or impairment in speech? Let's see the answers. Fantastic. That's a great public, and everybody did it right. It's cardiomyopathy. The other two are related to the compromise on the nervous system. So thank you so much. Let's go to the next slide. So how exactly the lack of energy production in the heart leads to cardiomyopathy? And let's just start with what is cardiomyopathy. Very simplistic, cardiomyopathy is a word that means disease of the heart muscle. And what happens in patients that have FA, that because of this lack of the energy, the cells of the heart, they're called cardiomyocytes, they actually need to try to compensate for this inability to beat properly. However, the way that they compensate in many ways is not physiological, meaning it's not healthy. So what you see first, and if you look at the image, you're gonna see a normal heart. In the middle, you're gonna see some thickening of the wall, meaning your cardiomyocytes, you always getting thicker, trying to compensate for the lack of energy. But what you actually is leading is a compensation that is not only is not healthy, but it's going to lead to a further deterioration of your cardiac function and heart failures. So as a consequence, we see first some thickening of the wall, and that usually leads to a even more hypertrophic heart. By hypertrophic heart means a heavy heart. And then unfortunately, sometimes end of loss of cardiac function, heart failure, and complications, including arrhythmias. So if we can go to our next slide. And why that matters? That matters because unfortunately the heart complications in FA are the ones that are the leading cause of early mortality in this patient population. We know that reports say that around 60 to 8% of the fatalities are associated with cardiac issues in FA. And we know by looking at literature that around 85% of the patients in FA may have some degree of heart compromise, and it can vary in terms of intensity, and usually presents, as I said, of thickening of the walls, what we call hypertrophy. Sometimes you can see associated with this thickening of the wall and injury to the cardiomyocyte, which are the cells of the heart. You can see some replacement of scar, what we call fibrosis. And associated with that, you can start to have some arrhythmia that can present a rapid heart rate, or you call tachycardia, or sometimes with irregular heart rhythm, many times called atrial fibrillation. So those are things that's why it really matters that we make sure that everybody gets checked for cardiomyopathy and is able to receive the proper management that they deserve. So in terms of neurological symptoms, they are much easier to be detected in patients with FA. They usually present first, and therefore they are more visible to the eye, and therefore they get diagnosed earlier. Unfortunately, the heart symptoms, they may be silent. The majority of the patients may present first with neuropathy, and that which is followed sometime over time with the development of a cardiomyopathy. In some studies, they show that after the patient is seen by a cardiologist or a neurologist, a year after, the majority of the patients may have some degree of cardiomyopathy. Unfortunately, because symptoms in people with FA, cardiac symptoms can be masked by the neurological compromise, many times the diagnostic is not being made. The cardiomyopathy signs and symptoms, if you look at your right, they're very similar to other symptoms in any other cardiomyopathy. They are not specific to FA, but sometimes because they mimic the neurological symptoms, you may not be aware they may actually be related to the heart. And they include swelling of the ankle sometimes, or the feeling of being bloated in your tummy. It can be chest pain. It can be dizziness and fainting, some shortness of breath, feeling tired all the time, and sometimes palpitations. Those are all symptoms that should be a red flag that you need to see a cardiologist. But even in the absence of the symptoms, is always great to check. And so let's go to the next slide that we look at ways that we can do the diagnosis. So usually the diagnosis of hypertrophic cardiomyopathy, actually any cardiomyopathy, is very easily done by a professional, by a cardiologist. You can do several methodologies. Probably the one that provides the most answers in a quicker fashion is an echocardiography, which is basically a non-invasive procedure that you can take pictures of your heart while the heart is beating. It does not require sedation, and you can identify if you have thickening of your walls, but you can also measure how well your heart is functioning. There are other tests that may help on the diagnosis, including a simple electrocardiogram that it can be done anywhere, any place. You can already you can detect some changes on the EKG that may be reflective of FA, so it could be a nice way to take a look and see if there are any red flags. And importantly, there is other methodologies that can be used, but both of them, both the EKG and the echocardiogram, are two modalities that are easily available in any hospital, any clinic, and it won't be something very difficult to accomplish as part of your routine check. Once you have that in place, usually it's recommended you follow with your doctor to this annually. And sometimes there is a need to also be checking for the presence of arrhythmias that they usually accompany the cardiomyopathy. That is done with alternative measures, including what we call Holter monitoring and loop monitoring. And those usually are recommended for patients that are higher risk of arrhythmia or they do already have palpitations. And both of them are ways to measure your rhythm over a longer period of time. While the EKG, you only measure for a very short period of around 30 seconds how your heart is beating. Most important of all, we always recommend that you consult a cardiologist and you're being followed by a cardiologist. That can be life-saving for patients with FA. Next slide, please. In terms of important point to make here is that even though we usually try to book all cardiomyopathies together and all hypertrophic cardiomyopathies together, they are actually several conditions or diseases that present the same way. They are like what we call phenocopies, or basically diseases that may look the same but are actually not the same. And therefore, it is very important that you are followed and you receive a therapy that is appropriate for your indication. And even within the same disease, every patient is different. So therefore, a treatment that may work for another cardiomyopathy may not be a good fit for you. And that's, again, what is very important to follow with a cardiologist, make sure that you're receiving the treatments that are available. There are some great news. There are treatments that can help with symptoms and can help managing the heart failure if you do have heart failure. So there are therapies that can help with symptoms, again, including diuretics. As well, there are therapies that can help with arrhythmias, and it can also prevent you have like life-threatening arrhythmias as a part of your disease. So this is all things that you should all consider when talking to your doctor. And again, there are approved treatments for FA. Skyclarys is standard of care, is always recommended, considering, of course, a case by case that you talk to your doctor. However, as of today, we are unaware of data that can demonstrate that Skyclarys can help the treatment of heart dysfunction. Again, things that you should be talking to your doctor and make sure that this is all covered. Can we go to the next slide, please? Another polling question: how well do you feel that you understand gene therapy and how it works? Not well, somewhat familiar, have a pretty good understanding, or I am an expert. Okay, amazing. That is very nice. We see like the majority of the people have either somewhat familiar or they have very good understanding. That's amazing. So thank you so much. And we do have, 13% that feels very comfortable with. So that's even greater to hear. So can we go to the next slide, please? So what is gene therapy? And we're going to try to do this in a simplistic way, like a nutshell. So the goal of gene therapy is to treat, prevent, or cure a genetic disease by targeting the underlying cause of the disease. In the case of FA cardiomyopathy, as we talked before, the manual of instruction of the gene, the variant, it tells the cells to produce less protein that you need. The way to potentially fix that, or to fix that will be to provide the cell with a new manual of instruction telling the cell to produce more frataxin. So that's a very simplistic way to look at. So the way that we do is by delivering to the cell, specifically inside of the nuclei of the cell, a new manual instruction, meaning a full gene, a full frataxin gene coding, so the cell can start producing more frataxin. In order to do that, there are a few steps that need to be done, and that's why this modality did not exist, 20 years ago, and is rapidly, probably in the last years, really becoming an opportunity to treat rare diseases. In order to be successful, there are two key things that you need to accomplish in gene therapy. One is the ability to go inside of the nuclei of the cell. So in order to do that, we need to use a vector, which is pretty much what we call a delivery system, or a code or a key that can open the nuclei of the cell and let the new manual of instruction or the gene that you want to provide to the cell inside of the nuclei. And second is very important, whatever delivery system they're using or vector, it needs to be a delivery system that deliver the new code, the new manual to the cells that it must need. In the case of FA cardiomyopathy, it will be a vector that makes sure that you deliver a lot of your new information to the cells in the heart. If you're talking about a different indication where the most problem happen in the liver, you're probably going to be looking at a vector or the liver system that deliver your medicine to the liver. So those are things that are part of the gene therapy, is not only having the gene that you want to deliver, the right one, but it's also having a way to deliver in the right cells and in the right location of the cell, which is inside of the nuclei. That's why the need of gene therapy, as many small molecules are unable to cross and go inside of the nuclei. So if we can go to the next slide, please. So what is it specifically in Lexeo2006, which it is an investigation gene therapy that is designed to deliver a functional frataxin gene, meaning a manual of instruction that can produce more frataxin into the heart cells. So as I said before, if you look at your right, you're going to be seeing inside of this structure, this crystal structure, you're going to see the frataxin gene, which is the new manual that is covered by this structure that is nothing more than a code that lets you go inside of the nuclei. If you look at the middle figure, when this vector goes inside of the nuclei, he releases the manual of instruction, which is the functional frataxin gene, and tells the cell that she needs to produce more frataxin. This frataxin then goes to the mitochondria, and the mitochondria then does the job that needs to be done, that is to produce energy to the cells and to the tissues that need the most. So the goal of Lexeo2006 is exactly to deliver a frataxin gene in heart cells, intended to increase frataxin protein production, and therefore with the hope that you can improve heart muscular function in patients with FA. Next slide, please. And let's go back a little bit, because about talking about clinical trials, I'm pretty sure that you're all very familiar, but it's always important to highlight that any new drug, including gene therapy, they must be tested in clinical trials before they can be approved for wider use. Clinical trials, usually they have steps, meaning they usually start very small with the main intent to prove safety. And as you progress, you actually increase the number of patients, and you start looking at signs of efficacy until you are able to prove that the drug is not only safe, but is efficacious in that treated population. And even after approval, there is still a need for stages that we call stage 4, where you're going to continue to be monitoring the safety and efficacy of the treatment, and then in a wider patient population. One important thing to remember, usually, especially in gene therapies, but in general, we usually start with an adult population to prove safety, and at that point, if there is a need, you start to look at the younger patient population, and that's based specifically on the safety, and make sure that you don't expose children to therapies that it can be harmful to them. So if we can go to our next step. Next slide, please. So let's talk a little bit about the two trials that they are looking at Lexeo2006 in patients with cardiomyopathies. So currently there are two trials ongoing. There is our Sunrise FA, and there is a parallel, sister or brother trial from the Weill Cornell medicine. Both of those trials are using Lexeo 0, the 2006, meaning it's the exact same product. They have very similar inclusion criteria, as well very similar metrics in terms of looking at safety and efficacy, and therefore, for the purpose of this discussion, the results for both studies are combined. At the time that we did this analysis, which was mid-July, there were 13 patients treated that received Lexeo 2006 at that point, combining both studies. Again, if we look at some of the inclusion criteria for both of them, are people 18 to 50 years old. Sky Clarity was allowed as part of the inclusion criteria. All participants receive a single time infusion of Lexeo 2006. The infusion usually lasts around 2 hours. And some of the key measures, the main measures, are the safety of this therapy. We are also looking at some early signs of efficacy by looking at images of the heart structure and function. And very important, we are looking at the expression of frataxin in the heart tissue. The expression of the frataxin in the heart tissue is done by collecting biopsies on the heart, and this is only being done in the Sunrise FA trial. The duration of the study for the primary endpoint, meaning the completion of the first part of the trials, is 52 weeks or 1 year. And then the patients, they continue to be followed over 4 years. And now I'm happy on the next slide to present some of the data. So first, let's look at safety. So far, Lexeo 2006 has been well tolerated and safe. And I like to remind that the safety is being monitored by an external safety committee, what we call DSMB, and there's our professional experts, all medical doctors that continue to monitor the safety of the trial and ensuring that safety of the participants, as well looking ahead how they're going to play out as we evolve and we go to the next step of clinical development. Next slide, please. So let's look at the heart biopsies and some preliminary data. All the patients that we have biopsies done so far, again, they're coming from the Sunrise FA trial. In all of them, we are observing increase in frataxin expression. If you take a look on the figure at your right, you're going to see a before treatment, and then at your left, after treatment, and you're going to notice that there are some black dots. Those black dots is frataxin, and each one of them, or most of them, are inside of some misshapen round figures. They are nothing more than cardiomyocytes. So each one of them are cardiomyocytes, and you see some black dots are the frataxin. And if you look at the pre-treatment compared to the post-treatment, you're going to see an increase on those black dots and more cardiomyocytes presenting a frataxin. So overall, we are very pleased to see, for the first time to our knowledge, frataxin levels in the heart pre and post treatment, and we are able to see an increase in expression of frataxin in all the patients that we've treated so far, and then we have biopsy. The next slide, please. So now let's look at a little bit more and look into terms of efficacy by imaging. And efficacy by imaging is basically looking at what we discussed before, the hypertrophy of the heart first, so how thickened the heart it is pre and post therapy. And so if you look at your right, this graphic, very simplistic, what we are looking at is how many patients had a reduction on hypertrophy, on a thickening of the heart at 6, 12, and 18 months, including all patients in the trial, independent of how much hypertrophy they had at the beginning. So that's a very important point. And we see that 12 months, half of all patients had an important reduction of LVMI. And in 18 months, the two patients that complete 18 months had more than 50% reduction of LVMI. LVMI is a marker of hypertrophy, is left ventricular mass, is how much the heart weight. And that's a way that we look at in terms of defining hypertrophy. Why we choose the 10%? Because 10% is a metric that allows to make sure that those changes are not happening by chance or just by the variance of the way that we are measuring. Of course, changes higher than 10% are even better, and we are seeing that in some of our patients already at 12 months. If you don't mind to click the next. So importantly, when we look at the patients that had more hypertrophy at the beginning of trial, then we see even larger improvements. And we see then 75%. And then again, here we are talking about 3 every 4 patients are showing more than 10% reduction in hypertrophy at 12 months. Of course, I caution us again, those are very early. We have a small sample size, but therefore it is still interesting to see the potential benefit of the therapy in the heart of these patients. And if we can go to our next slide, please. Now let's talk about 2 additional measures. One is thickening of the wall. If you remember when we talked initially that usually the hypertrophy starts with thickening of the wall, and over time you have a full, your whole heart is heavier, meaning the left ventricular mass is now bigger. At the beginning, what you see is a small thickening of the wall. And in a way, the thickening of the wall is an early indicator of LV hypertrophy. In the patients treated in this trial that we have follow-up data, the majority of the patients showed actually reduced thickening of the walls in 12 months, which it is a very positive sign. As well, it corroborates the data that we are seeing with the left ventricular mass index that I just showed you in the slide before. Next, please. So importantly, another marker that you may be familiar with is troponin I. Troponin I is a biomarker, a circulatory biomarker, but in fact, troponin I, it is an important part of the cardiac machinery, meaning the ability to beat the heart, and it is not expected that you have circulatory troponin, not in the levels that we are seeing in our patients. It's being fully reported that patients with FA have high levels of troponin. And what indicates to us that unfortunately, the presence of troponin in the blood is an indication that there is being heart muscle injury. If you remember when we discussed before, the fact that you have low energy in your cardiac cells, put those cells in a lot of stress, and you ended actually, unfortunately, losing some of those cells, and they're losing those cells. This injury is actually you're seeing in your blood, but having increases in troponin. When we look at the patients in our trial, the level of troponins in most of them were elevated at baseline, and we are seeing a 50% reduction on average in all participants at 12 months. Again, we are looking at 5 patients, again, small sample size, but the fact that we are seeing a consistent decrease in troponin is very reassuring. If we can go to our next slide. So in summary, let's take some of the key points that hopefully we made in this call is that hypertrophic cardiomyopathy or cardiomyopathy cells of serious complications of FA. The heart dysfunction due to the cardiomyopathy is unfortunately the cause of early death in a significant proportion of patients with FA. The diagnostic of cardiomyopathy is not necessarily all the time done, and specifically because symptoms may not be present. And even though you may not have symptoms, doesn't mean that you may not have a cardiomyopathy because of the neurological components that can actually make enable for you to have regular symptoms of heart failure. Lexeo2006 is an investigational gene therapy that is aiming to address the root cause of FA cardiomyopathy. We presented here preliminary results in terms of safety and efficacy of Lexeo2006. And we are happy to inform that as of today, the therapy is being well tolerated. And finally, we also presented some efficacy, looking at increasing of frataxin protein, as well as some markers of improvement in cardiac function and structure. And together, the data highlights a potential trend towards clinically meaningful improvements and the continuous potential of this drug to have a potential benefit in patients with FA cardiomyopathy. The next slide, please. I want to finish providing two important emails here. We are always happy and welcoming questions. We do have two outlets. You can even have questions about our clinical trial and our programs at clinical trials at LexeoTX.com, or you also can visit our patient and community portal, patients at LexeoTX.com, and we hope to see you all at the FARA Shop Symposium this weekend. We are looking forward to the event, and we are looking forward to do the ride on Sunday. So thank you so much. There is a final slide. And anyway, thank you again.